So thank you very much again for listening to me drone on. As we've seen, there have been a recent number of retrospective associative studies linking anticholinergic load and exposure in older people to incident dementia diagnosis. And we've seen a number of papers which have linked overactive bladder antimuscarinics in those cohorts, although there is no causal link, but people are obviously concerned. We wanted to look at the Fesoterodine data, which is probably the most extensively tested drug in older people, to look with a little more detail about MMSE. These are my affiliations. I've worked for both Pfizer and Astellas and Pierre Fabre in Europe, who deal with these drugs. So we've got the association. Heightened concern, of course, leads lots of geriatricians to stop these drugs, condemning older people to being miserable and wet, and that's not very nice. So we wanted to look at what happened to MMSE. And we hypothesized that people with low MMSE scores at baseline would show no consistent pattern in change. And we've seen other observational studies of other overactive bladder drugs using the MMSE, reporting populations having stable MMSE up to a year of exposure. So we used data from 2 randomized placebo-controlled phase 4 trials in both medically complex and community-dwelling older people. Each study collected data on MMSE at trial baseline and end of study, and we categorized change by any plus or minus 1 score into improved, no change, or declined. So there are 673 patients exposed to fesoterodine and 674 with placebo. The majority were white. These are the demographics from the studies previously reported. As you can see, actually, 1/3 got better, 1/3 stayed the same, and 1/3 declined over the time. Remained unchanged, as you say, in thirds. There was no difference between the placebo and fesoterodine exposed patients in the pattern of change across the groups. We wanted to look at those people who scored fewer than 25 out of 30 at baseline, what happened to them, and intriguingly, they all got better, suggesting that this is a measurement problem. It's a regression to the mean, nothing else. So for all patients, the thirds changed or stayed the same. Those people with less than 25, those who got better. Could be a learning effect, but it's unlikely because the distribution of scores that improved was similar to those who declined. We used a very conservative definition of change in the Aricept studies of dementia. A significant difference in change in MMSE was between 2.4 and 3.7. We used 1. We could demonstrate no other obvious pattern of either improvement or decline in MMSE, regardless of baseline score. And the take-home message, folks, is don't bother using it in this context. It's a waste of your time. Let's think of something else. We're currently testing the MoCA for sensitivity. The MMSE clearly isn't to the degree of cognitive change that you might see versus, say, in some of the more detailed studies of OAB drugs for cognition. Thank you very much. And thank you to Pfizer for funding the statistical analysis of a protocol and plan written by the researchers.
The floor is open to question.
Oh, good man.
Toby Chai from Boston. So I want to make sure I understand. So the MMSE is not a good instrument to look at it. So you can't say anything about this group of patients in terms of their mental state, their cognitive. Is that?
Well, no, it's good measure of cognitive state.
Okay.
But what we can't see any change in any meaningful way with 12 weeks exposure to therapeutic doses of OAB drugs. We lack very long-term data. We have a weak association from the epidemiological studies that grab the press. So it leads older people saying, don't take me off these drugs, or my geriatrician colleagues stopping them randomly without thought or knowing the data. So this should give us a bit of defense against that reflex, brainless reaction.
So, I mean, I missed it. When was these outcomes measured?
Baseline and after 12 weeks of exposure to drug.
At 12 weeks.
Or placebo.
So I'm still trying to figure out. So that data is 1/3, 1/3, 1/3.
Yes.
Sort of.
There's no pattern, no change.
There's no change.
Yeah.
So is that a good, to me, it seems like pretty neutral in terms of, I'm not quite
It
sure.
probably says two things. For those people who scored low, they got better. It's a regression to the mean. For everyone else, the MMSE is probably insensitive to the degree of cognitive change, if it indeed exists, over the duration of exposure. In the short-term detailed single or chronic dosing studies of OAB drugs, we can detect small changes in some of the things that my colleague has mentioned with immediate release oxybutynin, whereas we've been unable to detect any change with drugs like fesoterodine and solifenacin, even in those people with mild cognitive impairment. And we, as you know, the data around, all the guidelines say if people are in danger of developing cognitive impairment, don't use antimuscarinic. We don't know how people with cognitive impairment respond to anticholinergics in the absence of delirium. And we know that OAB drugs do not precipitate delirium, even in frail nursing home residents. Mike.
Michael Wishaw, Melbourne. Unfortunately, we don't have fesoterodine in Australia, but is this a better OAB drug from the anticholinergic group than others?
So it's been compared actively, obviously, against tolterodine. There are no other head-to-head studies. It's, again, the most extensively assessed purposefully in older people. We now do have a prospectively planned results from a mirabegron study showing effect in older people, largely, again, using the MoCA showing no cognitive effect.
Thank you.
Yes.
I'm Suzuki from Tokyo. Are you planning a new study a comparison study for long term, at least 3 months or 6 months?
I think
I think it is a little bit short to compare the 12 weeks. I want to know the long-term comparison.
Absolutely. So there are, I think, even Dr. Sakakibara with imidafenacin has looked at observational studies up to a year using the MMSE. I suspect that that's not good enough. We are currently doing a detailed study in mild cognitive impairment using the MoCA. And if we can show that that's sensitive to change, that would be useful. But again, I think a longer-term observational study for particular cognitive outcomes would be very useful. We know that cognitively reported adverse events for fesoterodine are probably around 1%. In the trials, but not related to dose or age, or numbers of medications you're on, or number of other things wrong with you.
So this drug is rank B in the Forta?
This drug is a Forta B, for those that know what it means, yes.
No.
Thank you.
I have a question for you, Adrian. I was wondering, you're recommended maybe the MoCA in the next trials.
We're testing
You're
the MoCA.
testing it.
We don't know whether it is
sensitive. It would be sensitive enough. What about a test for diverted attention, or a test for...
Absolutely. Bill's work showed that actually what we might do is simple reaction time. We know that simple reaction time is a very good indicator of impaired cognition.
So that could be added.
And it may be good enough. Or put them in a car and send them down the road.
And right now, these tests are not used in studies on medication.
No.
Thank you.